I think we're still extraordinarily early in the computer-aided and or robotic surgery. I mean, I do a lot of robotic surgery. In fact, 98% of my practice is robotic colorectal surgery. But I wouldn't really call it robotic. I would really call it, I know it's almost like a mainframe, like a dumb terminal. All it does right now, the only thing that the robot does is it translates my motion at a console into other motions at the bedside. Granted, the key features of the robot that are cool but not necessarily robotic are the other features in terms of visualization and articulation and instrumentation. But that's not the robotic part. The robotic part is really just a dumb terminal. And it's a means to the end of the articulation, etc. We don't really have digital surgery in the way that we think of it in terms of either augmented reality, improved visualization, and enhanced diagnostics, etc. We don't have that yet. We have some, augmented reality with 3D, but not in terms of real true clinical practice. I think, though there have been trials underway, there are a lot of companies in the arena who are trying to get input from other surgeons, etc., to see how it can work, and then we can either augment it or onlay it onto the actual tissue. We're pretty close, but we're still a little far away. I think that is going to be the next major leap, or it is the next major leap, particularly with improved visualization, and not just regular like white light 3D, but really targeted visualization and definition of anatomy and planes based on, molecular tags that you can then use either fluorescence or other kind of imaging, not necessarily fluorescence either, and or also combine it with preoperative imaging, whether it's CT or MR.
Thank you.
I think the biggest barrier, frankly, is going to be cost and access and availability. And especially initially. Even now, the cost of the robot can be prohibitive for many medical centers. I'm just talking about the U.S. I'm not talking about the rest of the world. I imagine it's probably even worse outside of the U.S. So that's going to be the biggest issue, and then adding another overlay of software, because really it's not the hardware, it's the software at this point. That's going to be the biggest issue, is getting the cost to be within reason, because we don't get paid any extra. The hospital doesn't get paid any extra to do these procedures with the robot or with augmented reality or this or that. The hospital gets paid X dollars for any procedure that you do within XYZ diagnoses, and that's it. The cheaper you can do it, the better. And if it doesn't really add true benefit, the hospital, especially now with reimbursements going down, they're never going to go up anymore. The hospital CEO or chief financial officer is going to say, hey, wait a second, you've got great outcomes. Where's the true benefit for the hospital and for the patient for this additional cost? That's going to be the critical thing. Because as it is now, paying X amount of millions of dollars for these devices and then all these extra add-ons, it's like you could buy a Porsche, right? And then, because Porsche is notorious for this, you buy the car. If you want GPS, that's extra. If you want this safety package, that's extra. If you want this, that's extra. And if you want Bluetooth, that's extra. Okay? Or you can buy a Honda, Toyota, or Hyundai. All of those are standard and for a lot cheaper than the base. Do you get anything different from buying the Honda or the Porsche? No. It's just physically or emotionally, most people would prefer to drive a Porsche than a Honda. I think the take-home message was we were trying to review why people were converting from laparoscopic to open or robotic to open, and whether there was any difference. And also if people were just doing open surgery to begin with, really a standard benign disease that we know already should be done in a more minimally invasive procedure. It's not a cancer. Why are you it's not harming patients, but why are you giving the patients the benefit of a more minimally invasive procedure for a benign disease process? And so the goal was to evaluate and see whether surgeons with lower or higher volumes and institutions with lower and higher volumes, and what was the compelling reason for conversion. And we found that when you're using robotics, more than likely because you already had some skin in the game, you're already interested in improving outcomes, you probably also already had more experience. They're surrogates for each other. Patients had lower conversion rates for this otherwise benign, yet it's a complex surgical procedure, but a benign procedure. So that's why we're trying to push for a more minimally invasive procedure, and maybe that the robotic approach would be easier than the laparoscopic, because it is hard with straight sticks versus articulation. I really think so. There's sometimes when we swayed a little bit out and said, oh, this is a little sexier if we do a single site or this and that, and then we realized that patients in the end don't care about the size of the incision or etc., whether you do a single site or this and that, but they do care about function immediately perioperatively and long term. And if we can improve the perioperative function and quality of life, both in immediate perioperative time for the next within 30 or 60 days, and obviously long term, that's huge. MIS over open surgery can get patients back to work sooner. They could be active participants in their lives and their family and work sooner, and that overall is with less pain, less narcotics, etc., etc. I mean, we have patients now that go home with 0 narcotics. When I was in training, at one point, we would give everybody 60 pills of narcotics, just routine, done. Now, I just send them out on acetaminophen and like ibuprofen or Celebrex, and this has a lot of positive features for the patients because they feel better, and then eventually, I have lots of patients who say, oh yeah, I'm going to do, I tell lots of patients, oh, I'm going to do this robotically or minimally invasive, etc. And all you'll have is a couple of little scars that eventually will fade, and your biggest incision is either going to be like this or like a dot if you have a stoma. And they're like, oh, I don't care. Which is an okay response, but then I say, I understand that, and I like that, except for the fact that we're going to cure this, because again, I deal with cancer. We're going to cure this disease for you. We're going to cure the cancer for you. And once all is said and done, you're going to have a reminder one way or another. But the less of a reminder, the better, because that means you can go and continue and live your life without always being reminded that I had cancer, down to yada yada. And body image is huge. If you're a man or a woman. For some reason or another, for women it's more important, especially if they're going to be wearing bikinis or whatever, or lingerie, etc. It's important, but similarly for guys as well. They don't want that constant reminder every time they get out of the shower, and they're dressing, or in the morning when they're dressing up, to see those scars. They want to be live their lives. Nobody really needs a constant reminder of what they went through. That's always, no matter what, it's always a negative point of their lives. Let's change that. Yeah, well, I think think there are. Unlike, for example, in the UK or other parts of Europe, where it's a national health system, and these national health systems, even in Canada, can kind of prescribe where patients can go, and we can really centralize, those countries can centralize that if you have a rectal cancer, you have to go here, or if you have, if you need a cabbage, for example, you need to go to one of these sites to do heart surgery. We don't have that in the U.S. The U.S. starting principles are of freedom and liberty, right? And so basically, when you get a medical license, you can do whatever you want on whomever you want, as long as you don't start killing people. That's the license. I can practice medicine, I can practice surgery, I can do whatever I want. So telling surgeons or physicians that they can't do operations for rectal cancer, radiologists that maybe they shouldn't be reading every MRI for rectal cancer, that's a hard, bitter pill to swallow. And so we did have unique challenges where, we're basically intruding and confining people's freedom and liberties to practice their way they think they sure can. And we have to do is we are trying to educate the physicians and the surgeons, and also the hospitals and health systems, and eventually also the payers, to say, listen, this is not like a simple disease process like a cough or a gallbladder. Okay, your gallbladder can be hard too, right? But this is a complex process that we know that if you actually dedicate yourself to this treatment, increase your volume and you have better outcomes both short and long term. And through that education, that's how we get buy-in. The other thing is we needed to make sure that when we came out with the standards, because we can't compel people to only go to the major academic medical centers, we don't have that ability to do that. We needed the processes and the accreditation to be near universal. Whether you're a small community hospital with one surgeon or a big major medical center with 12 surgeons doing rectal cancer, the same regulations, same standards apply and are equally applicable, and you should all get the same response. The goal of this process is that no matter where you go in the country, you get the same treatment, whether it's chemo, radiation, and/or surgery, or the combination, with the same outcomes. For example, it's the same thing like if you had an iPhone or an Android phone. It shouldn't matter whether you buy the iPhone or Android phone in Jerusalem, London, or New York City, right? It should be exactly the same. It should act the same. It should function the same. You can put in a SIM no matter where you are, and it's the same. It shouldn't matter where you go with it. That's the same thing. We're applying those same principles to management of complex medical diseases. I mean, that's the easiest thing. And that's part of the thing I enjoy the most. I was going to say second to actually operating, but probably equally so, because if I get buy-in and engagement of the patient and their family in their management, it goes a long way, because that really builds that patient-physician relationship. So my goal when I see the patient the first time, right, is not just to say, all right, you have X, this is the treatment, bam. It's really to educate them about what is going on and why we're doing it, and what their long-term outcomes are going to be. In fact, I focus more on long-term outcomes and prognosis and quality of life than I do on that episode of care, right? Because ideally, the episode of care, whether it's for some benign disease process, whether it's hemorrhoids, diverticulitis, etc., or complex rectal cancer, should be a finite period in those patients' time. What the patient really cares about is how it's going to affect them long term. If they're going to be around, if they're going to be able to work, continue working day to day, continue being able to go out with their spouses to dinner or a date, or vacations with their family to see their kids grow up and graduate, maybe get married. That's what they care about. Yeah, they care about the cancer or whatever, but what they really care about is their social, what impediments they're going to have on their social life, what impediments they may have and how functional they'll be professionally, and also sexually with their partners if they're involved. Right? Those are the three aspects of being a human being, right? Social, professional, and sexual, as a general rule, right? Because it's normal to be human and intimate, right? It's just a normal process. Otherwise, we wouldn't have a species. So by addressing all those features, because sometimes people are very afraid of that, and if you just come out in the open and talk to them about all those issues, that shows patients that you're engaged, not just in taking care of the disease, but actually taking care of them and their family. That's what they want. That's really why they came to you. Not, yes, also for the disease, but everything else. How it's going to affect them. I mean, I started attending this conference in 2007. And the reason I started attending this conference is because I was told by one of my mentors, who's since passed away, that this conference is perhaps one of the leading conferences, more so than even National Society meetings, where we get to learn about new innovations and techniques and management before it comes out and diffuses to the established societies, for example. And I think the integration and collaboration of an international, basically, fraternity or brotherhood or sisterhood, whatever we've yet to come up with a good, name for that that's not sexually biased, though. But the collegiality is fantastic. It is infectious. That is perhaps the best part of this meeting, where you can meet and talk to other, colleagues or other, even not physicians, surgeons, to exchange ideas. That's the key thing. The only way we can improve medicine and improve humankind is through the communication. Right? The answer to everything is always communication, right? That's always the problem. Like we were just talking about it, in the airplane. It was communication, lack thereof, or probably some hostility. But communication and exchange of ideas that lead to further innovation and further improvement. That's the best thing about this meeting, And yeah, you learn a little bit here and there.